Minister.
Thank you, Leanne.
All right, let's elaborate on this a little bit. We're talking about genocide. We're talking about big words, satanic killings almost. I mean, this was an article from the Mail and Guardian that you were quoted in as saying this. Give us a bit of background as to why you're using these words.
Well, I'm using these words because we came across a document. In fact, I must confess, we didn't know about it until the Mail and Guardian phoned us to comment about it. And we looked around, we got it. A document that is going to subvert what I will call progress within South Africa and the developing world by making drugs affordable, easily accessible to the citizens. In South Africa, it's much more important because we are facing a quadruple burden of disease. We are a very sick nation, which the biggest HIV/AIDS prevalence, as you know, the biggest TB prevalence, etc., etc. Now, when you want to make drugs affordable and somebody is planning secretly, conspiratorially behind your back to subvert that, which will lead to many people dying, many people not accessing treatment, wouldn't that amount to genocide? It will be, because many people die. You are aware that we still have 2.4 million people on treatment on HIV/AIDS. That in itself has saved people and increased life expectancy in South Africa. People were dying in large numbers very early, but because of that treatment, they are now alive. Now, we still have to scale it up by doubling it to 4.6 million, but if drugs are put beyond their reach by pricing, you are actually killing them. You are exposing them to HIV and say, go and die, we are not going to make drugs available for you because we won't afford them.
Let's put this in perspective for the viewers out there. And you, just before we came on air, showed me a very interesting graphic, and it's not about, this is not about antiretrovirals, but this is about cancer treatment. Just give us the background of this graph that's on screen.
What you are looking there on the screen, Leanne, and listeners up there, and viewers are out there, it's a drug called Cleavage. It's an anti-cancer drug. The first graph is what it costs in South Africa to treat one person per month.
Yeah.
That's per month, right?
Per month, and that's,
yes.
That's the figure there is
174,000.
174,000?
Yes.
All right.
Yes. Now, yes, that's what we are looking at there. Okay. Now, the new policies want to make it easier to produce generics, which is the same drug actually, chemically. Everything is the same, except that it's not produced by the original drug. The reason that original drug makers are expensive, is not because their drug is quality. No, not at all. It's because they argue that they spend a lot of money doing investigation, doing field tests. They'll tell you we tested this drug for 10 years. And we agree, yes, we agree that they get paid for that. But after they get paid for 20 years, that means the patent period is 20 years.
Yeah.
They've got the monopoly for 20 years. After 20 years, anybody else must be allowed to manufacture that drug. And the people who manufacture that drug after 20 years are usually very affordable, because the argument is that they never spend money in innovation. That is called a generic. What you are looking up there, the red graph, is the price of generic. And the blue are the prices of the original Cleavage. If you go to India, per tablet, you are going to pay 86 rand per tablet.
Yeah.
In South Africa, we are paying 876 rand per tablet. And this is the same drug.
Yeah. See,
and now the new policy is to make it possible for us to pay that 86 rand, because patients here also deserve it. You can imagine, Leanne, if you wake up tomorrow, they say you have got cancer, this drug is the only treatment, and you must pay 876 rand per tablet because somebody has gone into research. We've already paid that person for 20 years.
Yeah.
Yes. So we are not saying there must not be intellectual property. No, we're not saying so. We are not unscientific or against business. We are supporting it, but it cannot be that excessive. The other thing they are doing, which we want to change, is something called evergreening. The issue of intellectual property for 20 years was established by the World Trade Organization in 1995, when they put up TRIPS, trade-related intellectual property. They said you must protect these companies for 20 years. What they do in South Africa is that during that period of 20 years, they just come in, change one molecule in that drug, one section of it, and claim that is a new drug and apply for another patent. So they must get an extension of that 20 years. So this drug Cleavage in South Africa has been extended now to 2022. In other words, if we don't change the law, up to 2022 we'll be paying that price you
that
see.
That 876 as opposed
exactly,
to 86 rand.
Exactly.
Yeah.
Exactly.
And I mean, this is practiced around the world, what you're talking about. I mean, we see what's happening in India as opposed to what's happening here. And we're just seeing
India has already changed these laws.
Yeah, it's changed.
That's the intellectual property.
Yeah, yeah.
What we are doing is more or less along the same lines.
Along those lines as well.
Yes, India has done it, and that's why India is called the pharmacy of the developing world. All of us are running there because of this new laws in India. In fact, Leanne, out of the 8 million people who are on ARVs now around the world, 6 million are in sub-Saharan Africa. 80% of them depend on generics from India. If it was not generics from India, they would have been dead by now because nobody will afford to treat them. So our intellectual property laws, we want to align them in that direction where we make generics easily available to population, especially in the developing world.
When are we hoping to get this law going, in fact?
It has gone through the cabinet. It's now in the public for public participation to give inputs. Now, instead of giving inputs, we come across this secret document, which is going to be, in other words, the campaign is going to be run by a private company in America. But in this document, they are saying it's going to look like it's from South Africans themselves. They even say it must run by a visible South African, a black African, preferably a former government official, or a visible business person, or a visible academic. You, because you respect that academic or that visible South African, you'll think that the person is genuine when actually it's being controlled from America. Yeah. That's why I'm saying it's satanic, because you'll see the face of the person as a South African. They even say the campaign must be run along, compassion with the sick and the poor. That the government is being unreasonable. We are very reasonable. If the government goes on in this policy, the sick and the poor are going to die, when actually the opposite is the case. They say they are going to plant articles in the media with you people in the media, where you'll be standing here as Leanne and condemning me, when actually you are condemning me or something that comes from America, from a very greedy person, and is lying to the population. That's why I used words like satanic. You know, I told somebody in the Mail and Guardian that the last time I saw such conspiracy was when I read the Broederbond documents, how they were going to rule South Africa. Now this one, the danger about this one is not only about South Africa, it's about the whole developing world. They say South Africa is ground zero. If we lose the battle here, they say the whole developing world is going to use the South Africa as a model and we're going to lose out. So it's about not only profit, super profits, which are unnecessary. I'm not against anybody doing business, making a profit. After all, business about profit. I'm not against that. But super profit that will lead to so many people dying, that should not be allowed. It's evil. And that's why I'm saying it's genocide.
Well, I mean, now putting it this way, I mean, and one has to really look at this seriously, and we'll take it, we'll take this exceptionally seriously and watch the story very, very closely. But let's get back to our infection rate. It is declining. The infection rate is declining, but it doesn't mean that there are no new infections. What are you doing to prevent these infections?
Well, we're doing quite a number of things, Leanne. Firstly, you are aware that we're scaling up on condom use, more education on condom. Please play safe. But we are also encouraging South Africans to know their status. Since South Africans started knowing their status, when the president launched the HCT campaign, HIV counseling and testing, on the 25th of April 2010 at Natalspruit Hospital, since that time, 20 million people came forward to be tested. And that's why we're scaling up treatment. Now, people don't know that treatment is also a form of prevention. It has proven that if in one particular area, 60% of the people who are HIV positive are put on ARVs, the infection rate actually declines. Why? Because when you are on ARVs, you are not cured, but the viral load goes down. It's under control. Your chance of infecting another person goes down. In other words, you are removing the pool of infectivity by putting more people on treatment. So when we scale up treatment, like by doubling it, we are also preventing further infection. We are not only treating this individual, we are also making it difficult for the individual to give it to others who don't have it yet. So prevention is also I mean, treatment is also a form of prevention.
Absolutely. Just very quickly, I mean, we were with you when we administered the very first pill, the one antiretroviral pill. I mean, it was a momentous occasion.
The fixed dose combination in Garangua.
Absolutely. I'll never forget that day. How's it been since then?
Since that time, remember, when you launched, they were choosing specific groups of people. We were targeting 180,000 people. That was April last year. We are now at 700,000 of people who are on the fixed dose combination. And we could have been on more, by the way. And here I'm not blaming pharmaceutical companies. I just tell you the reality. In July, when we wanted to scale up, they said they can't cope. We must give them 3 more months to manufacture. They couldn't cope. The numbers we demanded was too much. So we are ready. As long as pharmaceutical companies can cope with the numbers that are wanted, we can treat as many people as we possibly can. Because, Leanne, it has also done something very good, which this IP want to accelerate and they want to reverse. We were paying 313 rand per patient per month. With a fixed dose combination, we are now paying 89 rand per person per month. That makes it possible to treat 3.5 persons with the same budget.
Yeah.
I'm actually saving you, the taxpayer. I'm saving your money by treating more people with lesser money because of the innovations. Now, we want those innovations to be accelerated. They say, no, Minister, you can't do this. You are interfering with intellectual property. You are interfering with business. It's not a good business practice. Investors are going to run away. That's the way they always use. I don't know whether these investors want to come to invest among the dead here in South Africa. I don't know whether that's actually what they are looking for, that people must die first, and in fact, investors will come flying. To invest on whom? On corpses.
Strong words from the Minister. Let's leave it there. Minister, thank you for coming in. Thank you for talking to us this morning. South Africa, I'm sure you've got a lot to say about all of this. A lot of truth and honesty, but a lot of facts spoken by the Minister here, talking about generics and the IP, and speaking about these global pharmaceutical companies that are against us using generics here in South Africa that could cost us a far lot less, and that's the truth. All right, Dr. Aaron Motsoaledi, thank you for your time. Thank you for being our guest on Morning Live.
Thank you.
All right,